at any time. 50 years ago, President Ford signed into law the Employee Retirement Income Security Act of 1974, better known as ERISA. And for half a century, ERISA has stood as the cornerstone of our nation's commitment to safeguarding the benefits of hardworking Americans. Congress has a responsibility to not merely create laws, but to conduct genuine oversight and better understand how the laws we pass impact the lives of our constituents. Today's hearing is a response to feedback from nearly 100 stakeholders on ERISA's implementation. As we prepare to discuss ways to improve the law, we should first recognize the vital role ERISA plays in ensuring access to employer-sponsored benefits, especially as it relates to health care. ERISA's strength lies in its preemption provisions, which provide employers with the certainty to offer consistent and comprehensive benefits across state lines. Without ERISA, multi-state employers would be left to navigate a patchwork of state mandates and onerous regulations. Efforts to undermine ERISA preemption threaten the stability of employer-sponsored health insurance. Without it, costs could rise for employers and employees alike. Unfortunately, a single-payer healthcare system is the actual goal of many Democrats on the other side of the aisle. Because ERISA reduces regulatory burdens, it allows employers to innovate to meet the needs of their employees and adapt to the evolving healthcare landscape. For example, when telehealth exploded overnight because of COVID, employers were able to respond quickly by creating new telehealth coverage options. Business owners drive American ingenuity, and almost anything the government does, the private sector can do better, and this especially applies to healthcare. ERISA allows employers to purchase new avenues for improving healthcare delivery and outcomes. ERISA fosters an environment where free markets can work and expand access to new cutting-edge treatments and benefits. However, the healthcare system of 2024 is vastly different than that of 1974, and it's clear from the response of stakeholders that there are ways to strengthen and improve current law. Clarifying fiduciary responsibilities for employers, promoting competition by preventing self-dealing, and facilitating greater data sharing are just a few of the steps we can take to empower job creators with the tools they need to lower healthcare costs and improve the quality of coverage for their employees. For too long, Congress has allowed the Medicare for all mentality to dominate our healthcare conversations, ignoring the fact that the majority of Americans don't have and don't want government healthcare. In fact, 153 million Americans have employer-sponsored health benefits. The private healthcare system isn't perfect, but a 2021 survey by Employee Benefits Research Institute and Greenwald Research showed that 63% of employees are satisfied with their coverage. I believe that more employer-driven flexibility, innovation, and competition will do far more to decrease healthcare costs than government-controlled price setting ever will. That's because competition, the free market, drives down costs, while government-subsidized healthcare places a greater burden on American taxpayers. I look forward to today's discussion, and I now yield to the ranking member for his opening statement.
Thank you, Mr. Chairman, and thank you for holding today's hearing on how we can improve upon the protection afforded to American workers and their families through the Employee Retirement Income Security Act, or ERISA. I want to thank all the witnesses for being here as well. When ERISA was enacted in 1974, Congress stated clearly that the fundamental purpose of the law was to, quote, protect the interests of participants in employee benefit plans and their beneficiaries. Accordingly, the law establishes consumer protection standards and provides remedies and access to the courts for workers whose plans are mismanaged. And critically, it ensures that those who serve as fiduciaries must administer plans for the exclusive purpose of providing benefits and may pay only reasonable expenses when they do so. While I expect that we will hear a lot today about the issues employers face, it's important that we not forget the fundamental purpose of the law. Any conversation about ERISA that doesn't put workers and their families at its very center misses the mark. Today's hearing is crucial. ERISA's impact on health coverage in the United States is substantial. The vast majority of people under the age of 65 rely on job-based plans for access to essential medical services. And with over 164 million workers and their families benefiting from these arrangements, the significance of ERISA in regulating many of these plans cannot be overstated. However, our workforce and healthcare landscape has transformed considerably since ERISA was first passed in 1974. The law originally included few substantive standards relating to health benefits when it was enacted. And over the past 50 years, policymakers have found that as a result, ERISA has failed to live up to its promise. There are still significant gaps in healthcare coverage for millions of Americans. Secrecy and excessive fees paid to third-party administrators and pharmacy benefit managers and exorbitant prices charged for medical care and prescription medication, all of which squeeze workers through higher premiums and out-of-pocket costs. While many challenges remain, it's important to note the progress we have made in improving the affordability of health care for workers and their families in recent years. For example, thanks to the Affordable Care Act, workers enjoy preventative health care services free of charge, and dependents can stay on their parents' health policy until age 26. Additionally, in 2021, Congressional Democrats passed the American Rescue Plan Act, which enhanced the ACA tax credits to lower monthly costs for low-income individuals and eliminated the subsidy cliff so that more low and moderate income individuals could get coverage. And in 2022, Congressional Democrats, these reforms strengthen access to benefits for millions of Americans. But there's still room for further improvement, and I hope we can work together in a bipartisan way on these issues. For example, there's much work to be done to ensure that job-based benefits, including long-term disability insurance, are available to people who need behavioral health care. Access to disability insurance is critical to ensuring workers have the financial security they need once they experience a physical disability or an illness that makes it impossible for them to work. Unfortunately, a recent report by the ERISA Advisory Council found that long-term disability benefit plans often place discriminatory limitations on coverage based on mental health and substance abuse disorders. The report contains several thoughtful recommendations on how to address these issues, including by applying parity for behavioral health to long-term disability benefits. I hope we can discuss this issue and others that will help ensure that ERISA lives up to its promise for workers and families. I look forward to a productive discussion and yield back, Mr. Chairman.
Thank you, Mr. Saulnier. Pursuant to Committee Rule 8C, all members who wish to insert written statements into the record may do so by submitting them to the committee clerk electronically in Microsoft Word format by 5 p.m., 14 days after the date of this hearing, which is April 30, 2024. And without objection, the hearing record will remain open for 14 days to allow such statements and other extraneous material referenced during the hearing to be submitted for the official hearing record. We'll now turn to the introduction of our distinguished witnesses. Our first witness is Mr. Russell Dubose, who's the Vice President of Human Resources for Pfeiffer Incorporated, which is located in Tuscaloosa, Alabama. Welcome, sir. Our next witness is Ms. Maren Mancino, who is the Senior Advisor for Policy at the Peterson Center on Healthcare, which is located in New York City. And welcome, Ms. Mancino. Our third witness is Ms. Karen Handorf, who is a Senior Counsel with Berger Montague, which is located in Washington, D.C. Welcome. And our final witness is Mr. Scott Behrens, who is Senior Vice President and Director of Government Relations at the Lockton Companies, which is located in Kansas City, Missouri. Welcome, sir. We thank the witnesses for being here today, and we look forward to your testimony. Pursuant to committee rules, I would ask that you limit your oral presentation to a 5-minute summary of your written statement. And I'd like to remind you, the witnesses, also to be aware of your responsibility to provide accurate information to the committee. We will now recognize Mr. Dubose for 5 minutes.
Chairman Good, Ranking Member DeSaulnier, and members of the subcommittee, my name is Russell Dubose, and I have the privilege of serving as the Vice President of Human Resources for Pfeiffer Incorporated, a mid-sized manufacturing company headquartered in Tuscaloosa, Alabama. I'm also chair of the Alabama Employer Health Consortium, a coalition of employers in my home state. Today, I'm testifying on behalf of the National Alliance of Healthcare Purchaser Coalitions. Its more than 40 regional employer purchaser coalition members represent private and public sector, nonprofit, union organizations, and more than 45 million Americans that spend more than $400 billion annually on healthcare. I'm here to advocate for the critical role that ERISA plays in enabling employers like us to provide high-quality, uniform health coverage to our employees across state lines. To do that, I'd like to tell you the story about how Pfeiffer has leveraged the flexibility of ERISA to relentlessly push for healthcare value for our roughly 2,700 employees and dependents spread across Alabama, California, and Pennsylvania. Throughout the 1990s and 2000s, maintaining competitive wages and benefits remained relatively stable. However, post-2010, we saw a notable increase in benefit costs, particularly health care. By 2015, it became evident that our current path was unsustainable, threatening both the affordability of our plan and the well-being of our members. Recognizing the urgent need for change, we enacted a transformative approach guided by our corporate motto, which is the Golden Rule. Inspired by the work of Dave Chase, the founder of Health Rosetta, an organization dedicated to transforming healthcare, and using the principles of Lean Six Sigma, we undertook dedicated efforts to reimagine how to deliver value for our families. Our flagship initiative is the Pfeiffer Cares Clinic, an on-site advanced primary care health center designed to provide comprehensive and zero-cost share healthcare services. By integrating elements such as enhanced access and contracting with high-quality providers, the clinic became a trusted healthcare partner for our plan members. Not only have we achieved significant cost savings, but we've also seen improvements in health outcomes, which reduce hospital admissions and better chronic disease management. Over the years, Pfeiffer has continued to expand our initiatives to include optimizing our pharmacy benefits by selecting a transparent, mid-sized PBM, direct contracting with high-quality providers, on-site nurses, patient care navigators, and a development of specialty programs like weight loss management. In 2023, amidst healthcare inflation, we pivoted our approach to focus on patient advocacy and wellness enhancement. This shift led to the launch of our zero-cost share Pfeiffer Cares Pharmacy, further enhancing accessibility and adherence to medication. Our commitment to innovation has allowed us to maintain a relatively flat net healthcare spend for the past 4 years. Year over year, we've reinvested the savings from our healthcare back into our workforce and community through an annual healthcare dividend. These dividends have created a virtuous cycle of positive impact by repurposing previously squandered dollars to support meaningful initiatives. To date, more than 100 dependents have received transformative college scholarships to local universities, including the University of Alabama, Roll Tide. And hundreds more have benefited from our summer enrichment program. In 2022, our dividend was used to end co-pays for our on-site pharmacy, sparing 1,700 families from cost sharing for prescription drugs. Our success at Pfeiffer is not an isolated case. Employers across the country are reshaping the healthcare landscape, driving towards better value and outcome for their employees. However, the foundation of our efforts, ERISA, is under threat. If ERISA preemption were weakened, employers would face a patchwork of state regulations, jeopardizing our ability to offer uniform, affordable coverage across state lines. This would undermine the progress we've made and force many employers to revert to fully insured plans, limiting innovation and driving up costs. Much of that threat comes from state legislation designed to regulate PBMs, which is itself driven by the lack of meaningful federal action to rein in anti-competitive practices. We strongly urge Congress to pass the Lower Cost, More Transparent Act this year, and go further by enacting legislation coming out of the Senate that would ban spread pricing and mandate full rebate pass-throughs to plan sponsors. My written testimony includes additional recommendations to help self-insured plan sponsors meet their fiduciary obligations under ERISA. ERISA has served as a cornerstone of employer-sponsored health coverage for 5 decades, enabling employers like Pfeiffer to provide quality care to our employees and their families. Thank you for this opportunity to share our perspective, and I welcome your questions.
Thank you, Mr. DuBose. And now Ms. Mancino is recognized for 5 minutes.
Chairman Good, Ranking Member DeSaulnier, and distinguished members of the committee, my name is Maren Mancino. I am the Senior Advisor for Policy at the Peterson Center on Healthcare, a division of the nonpartisan Peter G. Peterson Foundation. Thank you for the opportunity to testify today as you examine ways to build upon and strengthen ERISA and employer-sponsored healthcare. Founded in 2014, the Center is a nonprofit organization dedicated to making higher quality, more affordable healthcare a reality for all Americans. We seek to transform healthcare in the United States into a more efficient and cost-effective system by finding innovative solutions that improve quality and lower costs and accelerate their adoption at scale. My written testimony today contains a number of detailed recommendations we have identified through our work, including through a recent convening of employers and purchasing groups regarding data access and market challenges. Today, I will highlight a few of the key recommendations from my written testimony. First, Congress should strengthen employers' ability to access their own data. As this committee knows well, Congress has prohibited gag clauses in ERISA, yet third-party administrators continue to hinder access to claims data. Congress should act to fix this problem or direct the Department of Labor to issue guidance that expressly prohibits TPAs from restricting employer plan access to their members' claims data. Second, Congress should increase the utility of data available to employers. Even in its limited form to date, we have seen price transparency efforts motivate employers to use data in ways to promote competition. Yet more work is needed. Congressional actions to codify payer and provider transparency rules into law will send a clear message. Price transparency is vital to competitive purchasing. Employers also need utilization information to increase their understanding of cost and quality drivers within their own plans and how that compares to others when they design their healthcare benefits. To achieve this, Congress could create incentives to encourage employers and health plans to contribute to multi-payer claims databases. The information available through these databases can support employer negotiations and decision-making about health benefit design. Third, data needs to be made available to patients so they can make informed decisions about their care. The bipartisan No Surprises Act contained a provision called the Advanced Explanation of Benefits, which makes personalized cost estimates available to patients before they receive scheduled care. This provision was scheduled to go into effect at the start of 2022. However, the administration has delayed implementation. Congress should work to ensure the administration remains focused on implementing these requirements so that consumers have access to this actionable information. Fourth, lawmakers should promote greater competition within the employer healthcare market by addressing anti-competitive practices. We understand through our work that dominant hospitals and payers are exerting their market power via contracting terms that inhibit competition. For example, all or nothing clauses require insurers to include all of a health system's providers and facilities in their network, regardless of cost or quality differences. Most favored nation clauses also limit competition by guaranteeing that an insurer received terms from a provider that are at least as favorable as those provided to any other insurer, which prevents them from contracting with others at lower rates. These clauses give dominant organizations an unfair advantage over competitors and prevents new benefit designs and innovative contracting. Finally, Congress should expand the role of the ERISA Advisory Council or create a new advisory council to provide annual recommendations to Congress. Congress should ensure that this council is representative, balanced, adequately funded, and empowered to contribute ideas and topics for review. Specific topics for the council could include employer market costs, prices, and utilization trends, transparency, including price transparency, billing or location transparency, healthcare ownership transparency, data sharing compliance, issues around network adequacy, as well as benefit design trends. In closing, policy reforms that seek to improve employers' purchasing leverage and access to better data will bolster competition, equipping employers with the tools necessary to negotiate confidently in the healthcare market and meet fiduciary responsibilities. Thank you for the opportunity to testify today. I look forward to your questions.
Thank you very much. Ms. Handorf, you're recognized for 5 minutes.
Sorry. Chairperson Good, ranking members of the committee, and ranking member DeSaulnier, and the other members of the committee. Thank you for giving me this opportunity to testify. I have represented participants and beneficiaries in employee benefit plans for the last 40 years, both in the government and in private sector. Congress passed ERISA to protect the interests of participants and beneficiaries by imposing standards of conduct on plan fiduciaries and for providing for appropriate remedies, sanctions, and ready access to the federal courts. Plans were to be administered for the exclusive purpose of providing benefits and defraying reasonable costs and expenses of administering the plan. Those purposes are not being served. Those hired to administer plans operate under a veil of secrecy and charge undisclosed fees that have inflated the cost of care, defeating congressional intent that plan money be used primarily to pay for benefits. And plan participants seeking access to the courts to protect their benefits are increasingly faced with barriers and limited remedies. 65% of American workers are now in self-funded health plans that contract with large insurance companies for access to their provider networks and for claims administration. These large insurers are not directly regulated by ERISA and operate under a veil of secrecy. They will not give plan fiduciaries access to their claims data necessary to determine how claims are priced and whether their compensation is reasonable. They assert that they are not subject to the requirements in 408b2 to disclose their fees, thus leaving plans making it virtually impossible for plans to monitor the fees of their largest service providers. The CA's enforcement mechanisms terminating contracts is not practical where there are no alternative service providers in the geographic region or the alternative service providers engage in the same practices. When plans can obtain data, they find multiple mistakes that are revealed. They find that the price that is paid by the plans does not line up with the provider's posted negotiated rates. And they find that there are fees that have not been disclosed to them. A recent New York Times article reported how TPAs reprice out-of-network claims and charge a percentage of the difference between the billed and repriced amount as a fee. The participants are harmed because their providers, who have not agreed to the repriced amount, directly bill the patient for the remaining amount, in one case, $100,000. The plan is harmed because it pays a significant and undisclosed percentage-based fee for the savings, in one case, $50,000 for processing a single hospital bill. All of this increases the cost to workers who contribute to the cost through wage concessions, premium payments, co-payments, and deductibles. These costs make it difficult for workers and their families to get the care they need. A 2019 survey found that 33% of people with employer-sponsored insurance put off or postponed needed care due to cost. 18% did not fill prescriptions, ration doses, or skip doses of medicine. Significant numbers of workers carry substantial medical debt. It will not help if cost savings are achieved, but there are no consequences if plan fiduciaries do not follow the rules designed to protect workers and their families. In a recent case, doctors for a 27-year-old patient were unable to obtain prior authorization for an immediate heart transplant that would have saved the patient's life. They sought a 72-hour expedited external review, which they were entitled to under the law, but it was treated as a 45-day standard review. The patient died 5 days after the decision that eventually reversed the claim's denial should have been rendered. The patient's estate sued for disgorgement of the amount the defendant saved by mismanaging the claim, but the court said they were not entitled to that remedy. Workers attempting to protect their rights are faced with constant barriers. Their lawyers cannot get attorney's fees for handling their internal appeals. Workers are denied claims files. Planned venue provisions prevent them from suing where it's convenient. Arbitration agreements and class action waivers significantly hurt their opportunity to protect their benefits. Congress should consider this.
Thank you, Ms. Handorf. And finally, we'll recognize Mr. Behrens for 5 minutes.
Chairman Good, Ranking Member DeSaulnier, and members of the committee, thank you for the opportunity to testify today. And more importantly, thank you for taking the time to celebrate my friend, ERISA, leading to its 50th anniversary. My perspective comes from 16 years as an attorney specializing in ERISA law. I began my career at a national law firm and have spent the last 10 years at Lockton, the world's largest privately held independent insurance brokerage firm. Lockton works with nearly 5,000 employer and union health plan sponsors across all industries, geographies, and sizes. Our role as a broker gives us a unique vantage point to objectively observe the healthcare landscape. We help our clients design and operate their health plans in a way that is consistent with their workforce well-being goals and, of course, compliant with ERISA. This includes evaluating and providing accountability for insurers, TPAs, PBMs, and others. But enough about me and enough about Lockton. The real hero today is employer-sponsored healthcare and the plan sponsors who work diligently to ensure high-quality and affordable benefits for their workers and families. Like Han Solo has Chewie and Barbie has Ken, our hero is supported by an indispensable sidekick, ERISA. Employer-sponsored insurance is the bedrock of the American health insurance system, providing health coverage to over half of all Americans. As described in my written testimony, polling data shows ESI is well-liked, and it provides significant benefits to workers and their families, employers and unions, and the federal government. ESI would not be nearly as popular and effective without ERISA. Still, health plan sponsors face a three-headed monster: ever-rising healthcare costs, burdensome administrative requirements, and increasingly complex compliance obligations and litigation risks. Today, you have the opportunity to support the dynamic duo of ESI and ERISA, but it is crucial that you keep two guiding principles before you at all times. First, do no harm. Second, make it easier to provide high-quality and affordable benefits. First, do no harm. According to ERISA's drafters, the crowning achievement of ERISA is its preemption provision. ERISA preemption allows plan sponsors to offer uniform and equitable benefits, innovate, and respond to the unique healthcare needs of their workers and families. Sadly, we've seen states pass laws subverting ERISA preemption, and even the Departments of Labor and Justice have pushed a harmful theory undermining ERISA. The committee should stand firm against any attempts to weaken ERISA preemption, including calling into account wayward administrative agencies. Second, make it easier to provide high-quality and affordable benefits. This will benefit both workers and employers. We praise the committee for its work to increase quality and reduce costs, most recently with passage of the Lower Cost, More Transparency Act. We support that legislation, but we think additional modifications will prove even more beneficial. First, strengthen the prohibition on gag clauses to affirmatively require data sharing with both the plan sponsor and business associates supporting the plan sponsor, and allow data to be used in any manner and for any purpose permitted by HIPAA. Second, ensure timely and ongoing disclosures of transparency data in a consistent format. Third, require TPAs, PBMs, pharmacy purchasing coalitions, and other service providers to disclose their direct and indirect compensation. Fourth, hold TPAs, PBMs, and others accountable for compliance and reporting obligations related to their services. Fifth, allow for disclosures electronically and take other steps to streamline reporting and disclosure obligations. Sixth, work with the Department of Labor to help plan sponsors better understand and comply with their fiduciary obligations, especially their duty to monitor. Seventh, prohibit anti-competitive contract terms and downstream agreements with hospitals and providers. Eighth, consider ways to reduce pharmacy costs. Again, I thank you for the time, and I thank you for the opportunity to work with you as we join forces to support ERISA and ESI.
Thank you, Mr. Behrens. Under Committee Rule 9, we will now question witnesses under the 5-minute rule. I will wait to ask my questions, and therefore I recognize Mr. Wahlberg from Michigan for 5 minutes.
Thank you, Mr. Chairman. Thanks to the panel for being here, and happy anniversary, Mr. Behrens. I'm about ready to celebrate my 50th wedding anniversary, and it's been wonderful as long as we did the things that were necessary, even reforms of me during those 50 years to make it continue working. ERISA, as you've said, is a very popular tool for employer-sponsored insurance. And I guess the question I would ask, subsequent to what you, I think, very clearly stated how we as Congress protect it and continue the opportunity. What parts of the law do you believe are most crucial to maintaining this success and popularity?
I think the most important one starts with ERISA preemption. The preemption provision, as we see in the legislative history, is considered its crowning achievement. One of the key reasons why ERISA was developed in the first place was the disparate rules and patchwork of state regulation. And allowing ERISA preemption to stand will encourage employers to be able to be responsive to their workforce needs in the areas that as we talked about, the data show. Also think the ability to access and utilize data as outlined in HIPAA is incredibly important. And in addition, I think the fiduciary obligations are incredibly important, that as employers work to administer their health plans, they're doing so in the best interest of their participants and beneficiaries.
Okay, thank you. Mr. DuBose, this committee has championed legislation to increase transparency, lower costs, and encourage innovation in the healthcare market. Last year, the committee passed my legislation, the Telehealth Benefit Expansion for Workers Act, which allows employers to offer a standalone accepted telehealth benefit to all employees, which they were able to do during the COVID-19 pandemic successfully. What current barriers do employers face in offering telehealth services, and how would a separate telehealth benefit help your company and your employees?
Thank you, Representative Walberg. The barriers employers face with telehealth is, I believe the issues we face is with our providers. We have employees that live in multi-states. Our salespeople travel from state to state when they visit with clients. And when we are using our telehealth resources, our providers may not be licensed in the states in which our member is either living or traveling in. We take the approach that to solve that barrier, perhaps we should flip the script, and the provider, the state licensure, should be based on where that provider is located. So for example, if we change the licensure in Alabama, where our provider is located, and then that licensure would actually cover those plan members regardless of their domicile or their traveling status, that would alleviate the gaps that are created by the provider not having proper state licensure in other states. To support our facilities in California, for example, we had to license our providers in Alabama in the other states just to access our own employees, as an example, sir.
Okay. A number of responses to the committee's request for information cited burdensome state regulations of telehealth. What can be done under ERISA to lessen that burden in a greater way?
So we believe that ERISA provides the proper framework to allow us to be flexible. I would say threats to ERISA at the state level, our ability to have ERISA preemption is paramount to having that success and to be able to improve on the offerings that we already have.
Okay.
Thank you.
Ms. Mancino, in your research, you've convened panels of employers who are struggling to offer good health benefits to their employees in this market. And undoubtedly, you've heard many complaints and concerns from them. What is the top concern you heard from employers, and how would Congress address it?
Thank you for your question, Representative. I appreciate the opportunity to give this answer. I think through our research, the top concern has to do with access to data and information in order to make the choices that they need in designing a health benefit plan. As we heard from other witnesses, TPAs are placing restrictions on access to employers' data, which prohibits and inhibits employers' ability to understand cost and quality drivers within their own populations, and then then struggle to compare that to other like-sized, like-situated employers. So without Congress stepping in to provide access to that data, I think that there is, the employers will remain challenged in designing benefits that will meet the needs of their populations.
Thank you. I've gone way over. I apologize, Mr.
Thank you, Mr. Wahlberg. So I don't have to say, remember to stay within your time for everybody. Thank you, Mr. Wahlberg. And now I yield to Mr. Courtney from California for 5 minutes.
Thank you, Mr. Chairman. Actually, coming from a district which is home to the Yukon Huskies, I would just note I'm not from California. I'm from I represent Storrs, Connecticut, where the men's that's right. Yes. Anyway, thank you to the witnesses for being here, and I'm again also pleased that we're taking a moment to reflect on the 50 years that ERISA has been on the books and ways that we can build on it and improve it. During my time here, I think the most striking reform was in 2010 when we passed the Affordable Care Act, which via the Public Health Services Act amended ERISA to put in really some of the most powerful patient protections, eliminating pre-existing condition exclusions, ending the practice of lifetime limits, allowing the children of covered employees to stay on their parents' health plan until age 26. All of that was because Congress had the boldness to resist all the negative pressure to get those measures through. And today, I mean, I think they're just sort of viewed as a given in terms of the way plans operate. You know, I also would just note that a few weeks ago, the Republican Study Committee released their 2025 sort of budget alternative, and included in it was a proposal to cap the tax exclusion for employee-sponsored health plans, employer-sponsored health plans. Again, we're not the Ways and Means Committee. We're talking about other issues here today. But, you know, we went through the Cadillac tax fight, which was a bad part of the ACA. We managed to keep pushing it off before it actually took effect. And in 2019, a bill which I was the lead sponsor on passed the House 419-6 to strip the Cadillac tax from the tax code, and to this day, you know, it still remains a tax excluded benefit. So again, for some of you who are in the business, can you sort of comment in terms of what the impact of capping the tax exclusion would have in terms of creating really unfair and inequitable and, you know, outcomes by region where costs are different, healthcare costs are different? I see you nodding your head, Mr. Behrens. Maybe you can comment.
Yes. First of all, thank you very much for your leadership on helping eliminate the Cadillac tax. It was rather problematic, and it is simply the other side of the coin of limiting the exclusion. You know, we believe that when you look at the healthcare landscape, one of the things you alluded to is that a lot of the cost differentials, a lot of the high costs are driven by geography. A lot of the high costs are driven by certain care conditions. Yeah, in the data, it shows that costs for women tend to be higher than costs for men. And so if your plan population is such that you have certain characteristics in it, your costs are going to be more. That's not necessarily because you're providing excess benefits or anything extemporaneous that doesn't need to be in there. It's just a matter of fact. And so changes to the exclusion could have a very negative impact similar to what we expected to see if the Cadillac tax would have gone in.
Thank you. And again, when that proposal was released a couple of weeks ago, the Alliance to Fight for Healthcare, which was a really interesting coalition of employers as well as other fiduciaries and beneficiaries, whether it's Taft-Hartley plans, others, all have actually stayed together since the Cadillac tax repealed and immediately issued a statement saying, we do not want to go down this pathway. And Mr. Chairman, I would ask again that their statement be entered for the record. And in my remaining time, again, just to go back to the question in terms of the disclosure and transparency issue, Ms. Handorf, I think, again, you've heard the exchange here before in terms of just how, you know, particularly third-party entities, there's a need for more transparency in terms of helping with the way plans operate and cost. Maybe you could just comment on that in my remaining 40 seconds.
Yes, I think that one of the real problems right now with healthcare is that there is a veil of secrecy. Most of the PBMs and the TPAs will not give employers information that they need. And when you do find out information, you find out that there's no rules really that they're playing by. And so until you get transparency and some ability for plans to be able to get that information, we won't be able to fix the cost of care.
Great. Thank you. I yield back.
Thank you, Mr. Courtney. And I will now recognize myself for 5 minutes. And I'll remind the witnesses to pull the microphones a little bit closer, if you would. Mr. Dubose, I found your testimony most interesting as you described some of the great work that Pfeiffer has done to provide outstanding benefits, a quality work-life experience for your team members. You've taken great efforts and steps for the mutual benefit, well-being, and cost savings of the organization and your team members, and the government didn't make you do any of it. You guys did it on your own, so you're to be commended for that. More specifically, your written testimony notes the ways that your company has used telehealth so that patients across the country, particularly in rural areas, have access to important healthcare services. Can you discuss this a little further, how telehealth has helped you expand access to care while also delivering lower costs and lower premiums to your plan participants?
During the pandemic, we noticed many of our rural families suffered from a lack of transportation and access as providers were inundated with patients. And so we developed an internal telehealth solution with our own on-site healthcare clinic and offered 24/7 telemedicine to all of our family members. So we were able to provide additional access from their homes and created opportunities to improve their well-being. And so the framework ERISA allows us to be innovative. It's foundational for us to where we can create new policies and new techniques to protect our plan members. So the protections afforded by ERISA allow us to be innovative and expand. Now we provide telemedicine to all of our plan members. We found, for example, prior to that, Sunday afternoons, we had the highest emergency department use. And then since we adopted telehealth, we eliminated many admits to emergency departments on Sunday afternoon. And so we found actual tangible benefits by expanding telehealth to our plan members.
Very good. So are there any barriers you're facing now, any obstacles to continue to provide telehealth benefits to your employees since COVID expired? The pandemic has expired. What obstacles are you facing now?
The current system is working well. As some of those provisions are up for expiration, we're opposed to that. We want to see telehealth continue. We have found that telehealth has a very remarkable place in providing support for medical management, chronic disease management. There is a sweet spot for telemedicine, and so we find that threats to ERISA allow us to create harm for our telemedicine benefits because it would limit access that our plan members currently enjoy.
Very good, thank you. Mr. Behrens, despite efforts by Democrats and many on the left to try to force single-payer health care over the last 15 years or so, more Americans have private health insurance than Medicare or Medicaid or other Obamacare plans. Over half of Americans, I think you might have been the one who noted, have employer-sponsored health insurance. ERISA's preemption clause allows multi-state employers to follow ERISA rather than all state laws, and this provides the regulatory framework to maintain competition, the free market. If ERISA preemption is eroded, how would this impact employer-sponsored benefits?
I think there are several ways that it would impact employers. I mean, one of the first ways is additional costs and additional plan administration, especially in the workforce that we have with a lot of remote workers. Now, consider a small employer, an employer in Kansas City. You've got grocery store that has employees in Kansas, in Missouri, and you might have some administrative employees elsewhere. If you were required to comply with a whole bunch of different state laws, that would make things much more difficult. for employers. It would also tie their hands on innovation and the ability to be flexible and make changes quickly. For instance, in the pandemic, we saw that employers were able to quickly adopt more telehealth benefits, were able to quickly amend their plans to provide more benefits for behavioral health care, as well as testing and treatment. And so those flexibilities would be gone.
Would you be concerned if ERISA preemption was eliminated or faded away, that our country would move more closely toward a single-payer system?
Absolutely.
Thank you very much. With that, I yield back and recognize Mr. Norcross from New Jersey for 5 minutes.
Thank you, Chairman, and to the witnesses for coming here today to talk about ERISA, which few people outside this room really understand, and certainly for what it has done for both workers and employers over the year. I think it is a job well done, but also it means that there are some things that we can do to certainly improve it. And one of those, and I know the ranking member talked about mental health illnesses and some of the impact. It's common today. It's probably as common as it was before, but now it's out in the open that we can have this discussion about that. And the stigma surrounding mental health is dropping. Certainly not to where it needs to be, but it's going on. The numbers are 1 in 5 adults have some form of mental illness. So ERISA's Advisory Council issued a report examining the barriers that workers face to accessing their long-term disability, or LTD. Mrs. Handoff, could you briefly talk about the impact of not offering adequate long-term disability coverage for those dealing with mental health or substance use disorder on workers and their family?
I don't believe that mental health is treated the same way with disabilities as it is with health care. Many disability plans limit mental disability benefits if you're suffering from mental health problems to 24 months, which, and on the other hand, it's endless for other type of healthcare disabilities. Well, mental health disabilities are no different than healthcare disabilities. They both make it impossible for the worker to work. And so if we really want parity in mental health, we need to make it apply to mental health, to long-term disability plans, as well as to health plans. And that would serve a very important purpose.
And certainly the Parity Act, which talks about the enforcement mechanism that the Department of Labor could use, because right now we have the speed limits, but nobody's obeying them and there's no real recourse. So we want to make sure we do that. Let me just switch gears here a little bit. And the discussion on whether or not we tax our benefits, particularly in health benefits, has been around for years. There's unfortunately been some more discussion. I say unfortunately because I believe it would have a negative impact on what employers and employees would do. Mr. Behrens, if this happens, and that's a huge if, that we take away the tax status for our health plans, what do you think happens to the market? Not so much going to a single employer, or do they just turn it over to the employees and say, go find your own?
I think one of the first things that happens, obviously, if you change the rules around the exclusion, you're raising taxes. And so workers will have less money in their paycheck. I think the idea is that it would change healthcare, reduce healthcare costs, but we don't envision that happening based on the information that we have, the plans that we sponsor, that we work with. We think employers are actively working on behalf of their employers to provide good benefits that are in alignment with what the workers need. And so if the exclusion goes away, some of those benefits will go away. And so plans will get skinnier and narrower and be less beneficial to workers and their families.
Thank you. And it's, I think, worth noting that when we look at tax breaks in general, the vast majority goes to those in the higher income brackets. This is what I call the working man's tax break. And it helps in two ways. A, it helps them in their health care, mental health care, because they'll now be covered. Because if thrown back to the employee, they have to make those tough choices each and every day. Do I pay for sneakers for my kid going to school, or do I keep my health benefits? And those are decisions, unfortunately, that are very real. We believe that the idea of that exemption is the core for ordinary working men and women. Keep that. Let them have their tax break while you take your zillion-dollar tax breaks on the other side. This is the working man's tax break. And with that, I yield back.
All right, the gentleman yields. And now I recognize myself to ask questions. Over 40 years ago, my wife and I took our savings and started a construction company. As the company grew, we were able to offer employee health insurance, which was not only a great benefit to our employees, but it was certainly critical to recruiting and retaining talent. This year, we commemorate the 50th anniversary of the Employment Retirement Income Security Act of 1974, also known as ERISA. I am pleased that we are convening today's hearing to explore avenues to continue to enable small and large businesses alike to offer consistent and high-quality health care plans to employees nationwide. However, there is more that Congress can do to expand and strengthen this law, such as allowing self-employed individuals to be covered under ERISA, helping small businesses band together to offer insurance to their employees like we passed in the House-passed Choice Act last year, and reforming step therapy. Right now, the government is running all of health care. Mr. DuBose, what would it look like if under the Affordable Care Act, unions and the faith-based community were given waivers to run their own health care plans without basically privately, without government interference? What would it look like if ERISA, along with folks, self-employed folks, able to participate in ERISA, what would it look like if ERISA got the same waivers and companies like yours were able to run your programs without having to answer to HHS and CMS?
Thank you, Representative Allen. We believe ERISA provides a minimum set of protections through its framework that allows us to innovate consistently in our multi-state plan. That's very important to us. If those guardrails were to change, then I believe that would create risk for our plan design and ultimately would harm our working families. We support that. If we no longer had to report to CMS on our pharmacy data and those type things, I would suspect we would even be more innovative in the way that we craft our plans to further lower a cost for all of our plan members.
Well, that's the idea, is to lower costs, and that's what, at least we know, the faith-based community, or better known Medishare, offers to folks. We passed the Lower Cost, More Transparency Act in December, which was intended to improve transparency in PBMs. What's your opinion of the bill and proposals to improve the transparency?
It is a fantastic bill. We support the transparency aspects. I will say that we do urge Congress to go further. There needs to be PBM reform, especially in regards to spread pricing and rebate pass-through. There are practices within those industries that ultimately create higher costs for our working families, and we urge Congress to consider addressing those issues.
Thank you. Mr. Behrens, as employees look for ways to control health care costs, it's amazing the people who benefit by selling new tactics in the name of cost savings, like alternative funding programs or AFPs, or taking advantage of employers by not giving them the full picture. In your opinion, should plan sponsors be required to clearly inform enrollees of the existence of an AFP and the specific conditions the program impacts?
When it comes to AFPs or any of the prescription drug models, I believe ERISA's disclosure requirements already require that information be provided about that. I'll tell you from our experience, employers tend to shy away from those types of programs simply because of the challenges that employees face with having to comply with those and some of the risks related to them.
I want to thank you also, Ms. Mancino, for sharing your thoughts on telehealth and Mr. DuBose. That's critical to healthcare. I'm out of time, and so I yield back. Who is next? Ms. Jarapal, you're recognized for questions.
Thank you, Mr. Chairman. Our healthcare system is broken and high costs are crushing workers. Meanwhile, CEOs of big insurance companies rake in billions of dollars in profits, and their executives make tens of millions. When Democrats held the majority in the House, we worked to improve regulation of big insurance and lower healthcare costs for workers. In the Affordable Care Act, we capped the total out-of-pocket costs allowed in health insurance plans, and in the Inflation Reduction Act, we went further and capped the out-of-pocket costs for prescriptions at $2,000 for people on Medicare, and that'll begin in just a few months. Now, President Biden has called for extending that cap to everyone who has insurance to make big insurance pay its fair share of medical costs. My colleagues across the aisle have advocated for repealing many of these health insurance laws and decreasing regulation of big insurance. Ms. Handorf, in your testimony, you discovered how current law allows insurance companies that administer group health plans to avoid the regulations in the Employee Retirement Income Security Act. Can you provide examples of how this has affected workers in their real lives?
Yes, I think that by not providing the information that's necessary for fiduciaries to control cost and find out how things are actually being run, it's caused, I represent two Taft-Hartley plans in Connecticut who tried to get their plan data from Elevance and were not given the data. They wanted it because in one of the plans, the plan had to increase the deductible so high that their members were not going to the doctor, they weren't taking the medications because they couldn't afford it. And so that's why they wanted to find out what was happening. And they reached a stonewall. We actually had to file a case in federal court to get that information, which has not yet been resolved. But when you do find out what happens, you find out that the claims are not being paid in accordance with the negotiated rates, that there are fees that are being hidden from the plans, and that there's just no rhyme nor reason to how these plans are being operated. So unless ERISA makes it clear that these TPAs are fiduciaries, or at least gives access to employers the information they need, and somehow is able to balance the bargaining power between the insurer and the plans, it's just going to continue the way it has been.
And given the lack of regulation of big insurance, can you tell me how healthcare costs for employers and for employees have changed over the past decade?
Yes, well, as costs have gone up, and there's no question the costs have gone up, employers are finding ways in which to share those costs with employees who already have given up some of their wages in order to get health insurance. And so you see in a lot of instances the deductibles going up very high, to the point where if you have a huge deductible, you're not going to go to the doctor. So it immediately affects them. And then when you have things like this, what the New York Times reported, it also affects employees in the sense that they get stuck with bills that they shouldn't be stuck with because the insurers are claiming 30% of the savings by repricing the claims. So all of these practices hurt participants, and I don't think we know the extent of them without more information.
What recourse do workers have if their medical care is denied by their group health plan? Is it easy to navigate the appeals process under ERISA?
Unfortunately, no. Number one, it's very hard for participants to get health care lawyers to take their claims because they aren't big claims. The lawyer will not be compensated for the work in the internal appeals procedure where the record is made, and so there's a limit to what the record can be. And then sometimes they ask for records and the plan won't give it to them, so it makes it very difficult for them to assert their rights to benefits. Their doctors usually know what's happening, but their doctors can't bring a claim because there are anti-assignment provisions in the plan documents. So there's all kinds of barriers.
Of barriers, yeah. And it doesn't sound like with these increased costs that they're getting better care or benefits.
No, I don't believe so.
When left unregulated, big insurance increases costs and decreases care for people. That's what I'm seeing from my constituents every single day. And it is really important that we continue to pass policies that rein in big insurance and work towards affordable health care for everyone, like my Medicare for All Act. Thank you, Mr. Chairman. I yield back. Madam Chair, I yield back.
Thank you. Mr. Bean, you're recognized for 5 minutes.
Madam Chair, a very good morning to you and good morning, HELP Committee, to our witnesses. We're glad to have you in our nation's capital. We're talking health insurance and the efficient delivery thereof. Mr. Behrens, you said don't do any harm, and I understand that. But here's our first question. Earlier this year, a bipartisan group, 39 state attorneys, state attorney generals, including Attorney General Ashley Moody of my free state of Florida, wrote to Congress urging us to take action on pharmacy benefit managers, PBMs. Their letter outlined several PBM practices, such as spread pricing and tying compensation to the list pricing of a medicine. According to these AGs, the practices affect patients and important stakeholders, employers, and community pharmacists, and also could increase the cost of health care delivery. Ms. Mancino, what say you? What should we be doing? Is there a problem with PBMs, and what are your thoughts on it?
Thank you so much for your question. I think it's really important that Congress do two things in this area. And based on our research, we feel as though Congress needs to provide vendors and clarify that vendors such as PBMs have clear obligations to current ERISA fiduciaries. If you provide that type of guidance, I think that the market can take that information and it will improve the visibility and the understanding of contracting terms that exist in that market. I also think that it is important that the Congress provide additional clarification and tools to current fiduciaries, including empowering them with access to meaningful data to carry out their roles.
Mr. Behrens, Ms. Mancino says action is needed. First of all, is there a PBM problem? And two, what should we do about it if there is?
I think she's exactly right. Additional transparency will be very helpful, and we
So there is a problem. There's a problem.
There is a problem with the lack of transparency, with the opaqueness, and many times we also see, as Ms. Handorf has mentioned as well, lack of transparency around fees. In addition, and so holding them to account. To provide that fee information under 408B2 of ERISA, the indirect and direct compensation would be beneficial.
More sunshine is the answer. Is that the answer, Mr. Behrens?
It is part of the answer.
Very good. When you leave your job, if you were to leave your job, and now I think it's an average of 7 times, the millennials may leave their job even more than that. The average as a few years ago was 7 times. But when you leave your job, you always got to find new health insurance. But you don't have to find new house insurance. You don't have to find new car insurance. Is it time that we create a market out there where people can be responsible for their own health care? How great would it be to see a commercial saying 15 minutes could save you 15% on your health insurance, or so easy a caveman can do it, and let people make their own decisions? Is that a good idea? Is it past time that we start our own healthcare market where people can make their own decisions and have their own health insurance without going through their employer? I throw that out as a toss-up question. Mr. DuBose, jump in.
In practice, I don't think it's applicable yet, because the players in healthcare, even if it's a new insurer, a new provider, those actors, the simple matter of the fact is many of the goods and services are just overpriced. So those same problems are going to creep up in.
But if we had a free market with some of the same protections that ERISA has given employers, wouldn't that be just a better way to go? It's kicking our tail right now. The healthcare costs are eating our lunch financially. And so isn't there time to do something different? We've done it this way for so long, but what can we do different? Mr. Behrens, what do you think about this new concept where people control their own health care?
I think in a lot of ways, people are able to. They have the choice. If you're leaving employment, you have the choice of continuing.
Your choice is take the company plan or not take the company plan.
You've got the choice of enrolling on the ACA marketplaces. You've got the choice of enrolling potentially in a short-term limited duration plan. You've got the opportunity, depending on your eligibility, to enroll in Medicare or Medicaid. I think there's options out there, and I think fundamentally there are still challenges with each one of those options.
Yeah. You're saying go to Baskin-Robbins and just take vanilla, and that's it. So hopefully we can have a general discussion, keep going forward, and think differently. Mr. Chairman, I yield back. Thank you very much. Great discussion.
Thank you, Mr. Bean. Ms. Manning, you're recognized for 5 minutes.
Thank you, Madam Chair, and thank you to our witnesses. And Mr. Bean, I just must say, I love your enthusiasm. I agree with you that people should be able to get their own health care, and that's why we passed the Affordable Care Act. And that's why, in my state, I am so thrilled that we finally, after all these years, decided to take Medicaid expansion so that people could afford their own health care. And I just want to use this to say, Mr. Barron, thank you for mentioning the Affordable Care Act, because it is such a critically important component of what people can now use to get their own health care. Ms. Handorf, the Biden administration finalized an important rule that would roll back the Trump administration's expansion of short-term limited duration insurance. Some would call it junk health insurance. And I have recently had an experience with a constituent in my district who thought she had good health insurance because she had gotten one of those short-term limited duration insurance plans. And then when she got sick, she learned it didn't cover anything. So I know that these plans serve as a stopgap, but were expanded far beyond the purpose by the Trump administration. So can you talk to us about how these plans differ from ACA compliant coverage?
Well, one of the things they do is they don't cover pre-existing conditions, so that if you have a pre-existing condition, you're not going to be able to get care for that. It also limits the type of benefits that you can get. I believe mental health benefits are limited, pregnancy benefits are limited. So you're not getting the same quality that you would get otherwise. And I think there are a lot of marketing techniques that make it sound like you're getting a lot more than what you're actually getting. So the value doesn't add up to what the cost is.
So in many circumstances, these plans offer a false promise to consumers?
Yes, they offer false promise.
An important protection that was established by the Affordable Care Act is that it allows consumers to seek an external review of the adverse benefits determinations by their health plan or insurer. And this is important because it gives people access to an independent review of their situation while avoiding having to go through the court system. But I think, as you noted in your testimony, the time it takes for an external review can have tragic results. So how can this process be improved?
Well, the process can be improved. The law is there to give you prompt external review, but if people don't follow it, there's no consequences. As the case I pointed out with Mr. Rote in the Rose case, where
so there are actually no penalties if the rules are not followed.
Exactly, because there are no penalties, and the participant is limited in what relief they can get.
And do you believe that independent review organizations for self-insured plans have the potential for a conflict of interest?
They do if you leave them in the hands of, if they're, I think that with any review process in ERISA, when you have the same reviewers over and over again who want to be employed, they tend to give a decision that's going to make sure that they get chosen the next time.
Thank you. Ms. Mancino, you mentioned that the lack of competition resulting from the consolidation of hospital systems can have an impact on costs. I know that in my own district, the pressure on our major hospital system to merge with a larger system is enormous, so that they can get more leverage to negotiate to achieve lower costs. But I'm concerned that mergers and consolidations actually provide worse care for my constituents. Can you talk about how we should be addressing that difficult balance?
Thank you very much for this important question. I think that the role that Congress can play here today and in the future is to address anti-competitive behavior that exists in concentrated markets. We would really like this committee to focus on continuing to advance data transparency, codify price transparency, make it clear that TPAs cannot hinder access to employer claims data, encourage the administration to implement the bipartisan advanced explanation of benefits requirements, and incentivize employers and health plans to contribute their healthcare claims data to multi-employer claims databases to help drive better purchasing and benefit design choices in concentrated markets. And we think you should address anti-competitive contracting practices like prohibiting all or nothing or anti-tiering contracting practices.
Thank you. My time has expired. I yield back.
Thank you, Ms. Manning. Mr. Burleson, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. DuBose, sorry. You know, when I think about how messed up the healthcare system is and how expensive it is, I can't help but think about how this place has totally taken an industry and turned it into a Frankenstein. That you've got a scenario that first, when people used to have choice, and as my colleague was mentioning, at one point, you know, people don't go and shop for health insurance today because it's being done by their employer. And why? Because the employer gets the tax benefit, and the employer is required to provide that. So we've consolidated and taken away the choice for employees at a company and said, if you're going to get insurance that's subsidized and you don't have to pay taxes on it, it's going to be through whoever the employer picks. Is that correct?
So in a self-insured plan that we have providers. We do offer centers of excellence and high quality providers based on quality.
And I'm not talking about the providers. I'm talking about the network, the insurance network. You pick the network.
Yes, in Alabama, we do have essentially one network, and we do add to that network through direct contracting. But in Alabama, our network does cover all the providers in the state with our carrier. So we have a different choice proposition in our state.
Right. So at the end of the day, we've in order for the sake of providing this tax benefit, we've eliminated choice to individual insurers, right? Individual covered lives no longer have the same choice that they once did.
I don't agree. We have a lot of good.
Not if they're going to get the same tax benefits.
Yeah. So in Alabama, the way our market works, the choice that we provide to our plan members is to go to the providers of their choice within the totality of the network based on quality. So we are able to navigate through innovation to those best of class providers, right, and let the plan members make that conscious choice, an informed decision to see the provider that they feel the most comfortable with, that has the best outcome, best quality, best cost. So it's a decision that the plan member needs to make, but it needs to be an informed decision. But it's not, in our state, the network itself is not what's in play because all of our providers are in the same network.
Because you understand that's not the way it is across America.
It is not. It is different from state to state.
Okay. So because in communities like mine, there are basically two networks. And if you are a member of one and your employer decides to go to the other, you have to leave doctors from one to the other. So you're lucky. You're in a Goldilocks community in that regard. But okay, so my other question has to do with the difference between the ERISA plans and the state regulated plans. What are the benefits that an employer receives to use an ERISA plan over what is regulated by the state?
So the benefits for us for ERISA plan is the fact that we're able to offer our plans multi-state and remove variance and make sure we have high quality plans that are consistent with all of our plan members, regardless of their location.
Right.
So we create innovative, high-performing plans because ERISA allows us that framework to excel, as opposed to a state plan that doesn't have those same luxuries.
Right. And so, because I'm hearing that while the ERISA plan is preferable, really what you're avoiding is a lot of state mandates on insurance. Is that accurate?
Now, in Alabama, what we offer in our ERISA preemption, in our ERISA covered plans, we believe we excel. We
I'm
far
sure that it
outprovide
could be better. I'm just saying
plans.
that you've got one size fits all mandates that sometimes a state implements that can be a tail that wags the dog.
So in the state of Alabama, we do use our ERISA preemption. So when the state does pass laws or policies that are unique to providers within the state, those are generally for state-covered entities that are not ERISA-covered plans.
Thank you.
Thank you, Mr. Burleson. Ms. McBath, you're recognized for 5 minutes.
Thank you so much, Chairwoman and Ranking Member DeSaulnier, your staff, and our witnesses that are here with us today. Thank you so much for making this hearing possible for us. As I've shared with the committee before, I am a 2-time breast cancer survivor and the daughter of 2 healthcare professionals. My father was a dentist, and my mother taught nursing at Howard University Hospital. Healthcare, as you can see, is very, very personal to me. And I've seen this industry not only as a patient, and from the perspective also of a provider. And I know that there's still so much work that we can do together to really ensure access to affordable health care for our constituents. I'm glad to be here today as we look toward ERISA's 50th anniversary and reflect on ways to improve health care delivery for the folks that are counting on us back at home. Step therapy is an insurer or pharmacy benefit manager mandated protocol that requires patients to fail other treatments before they can take advantage of the actual medication recommended by their doctors that in most cases really is the best medication, but they've got to work their way to get to that medication. Often failing medication can result in debilitating side effects and irreversible disease progression. And I will say that I actually have gone through this with my own husband, who has been diagnosed with a very rare autoimmune disease. So last time we gathered here to discuss employer-sponsored health care, I shared how my husband was actually being stepped through the wrong medication in order to obtain coverage for a therapy that our doctors knew would be better suited for his treatment. So I'm really proud to be working with Representatives Winstrup and Chavez-DeRemer on the Safe Step Act. Our bill would actually offer a streamlined procedure for processing step therapy exemption requests and return these personal decisions to where they belong, with the patient and with their family and their health care provider. I know what it feels like to walk hand in hand with a sick loved one and to see them go through the fear and the uncertainty of their diagnosis. So when someone you love is sick, all you want to do is see them get the care, the medication, and the services and the support that they need to get better. And the last thing anyone wants to hear is that their husband or their sister or their child, their care is being jeopardized in order to just kind of like check a box. Some patients simply do not have that luxury to wait. And I know in the case even with my husband, it was a matter of days, really, actually, had we not been able to ascertain what disease he had. His disease can be fatal if not managed. So I just want to say, always, we have to be thinking about the patient's care foremost in mind, because our patients really can't wait. My question is for Ms. Handorf. Do you think it's appropriate for pharmacy benefit managers to refuse to cover an employee's treatment, even if it will result in irreversible health outcomes or death?
I think that costs usually end up driving decisions when they ought not to. And the bottom line should be that the benefits are for the participants' best health. And I think that when pharmacy benefit managers control the pharmaceuticals that participants have access to, ultimately it doesn't result in a good result, because it's just going to cost more in the long run. Mm-hmm. That's, of course, assuming that the patient lives for the second therapy or the other drugs. So I think there should be control of that situation.
Thank you for that. And can you talk a little bit more about pharmacy benefit managers and how important it is to have more transparency, which we have talked about that today, but really, if you'd like to elaborate even more about the transparency for the American public when it comes to what they do and the decisions that they make.
Well, I think that it's very hard to understand how you can control costs if you don't know what your service providers, both PBMs and TPAs, are doing. And I think that transparency is difficult to define right now, because we don't even know what we're looking for that needs to be open to the public view. But I think it's essential for employers to have equal bargaining power with their service providers in order to be able to really control costs and provide good benefits.
Thank you so much for your testimony, and I yield the balance of my time.
Thank you, Ms. McBath. Ms. Hayes, you're recognized for 5 minutes.
Thank you, and thank you to our witnesses for testifying here today. I'm happy to be here. However, I recognize that we are still just nibbling around the edges, and we need to address healthcare in this country in a real and meaningful way. According to the Peterson KFF Health Systems Tracker, the majority of individuals under age 65 in the United States receive their health coverage through a job-based plan, including more than 164 million workers and their family members. While people are generally satisfied with their employer-sponsored plan, the cost of health care is still far too high for many. According to the Centers for Medicare and Medicaid Services, health care in the United States are among the highest in the world, accounting for over $4.5 trillion in 2022. Those are policy choices. Despite this spending, we have worse health outcomes than other developed nations. This Congress has had a large focus on the lack of transparency in this market due to pharmacy benefit managers, or PBMs. This committee even marked up legislation included in the bipartisan Lower Costs, More Transparency Act, which would improve transparency regarding PBM rebates. Employers who sponsor health plans are often unable to determine the basics of how PBMs make decisions with respect to their plans. With respect to their plans' prescription drug benefits, including where rebates they earn and whether those rebates pose a conflict of interest that raises costs for workers and their families. Mr. DuBose, in your testimony, you pointed out the need for federal standards for PBMs. How do rebates impact how a PBM designs a formulary? Additionally, how does that affect consumers in terms of their premiums and out-of-pocket costs?
Thank you, Representative Hayes. Yes, we believe the PBMs, they control the formularies. And when it comes to pharmacy costs for a employer-based plan, the formulary is the driver of those expenses. So we have seen, and which was the reason we moved to a mid-size transparent PBM, is because the placement of some of those formulary items are driven by the rebate model as opposed to lowest net cost. So we encourage our fellow employers and plan sponsors to focus on lower net cost, because at the end of the day, that equals lower costs, lower premiums for plan members.
Thank you. According to the Drug Channels Institute in 2023, 80% of all equivalent prescription claims were processed by 3 companies: CVS Health, Express Scripts through Cigna, and Optum Rx through United Health Group. Like many others on this committee, I constantly hear from constituents that they are either paying too much for prescription drugs or they cannot find the drugs they need because of pharmacy consolidation. How does this market concentration impact the employer's leverage in negotiating for better health plans? And is increased transparency regarding PBM rebates enough to lower health care costs? Mr. DuBose.
Yes, Representative Hayes, the recommendations we have outlined are necessary, but I do believe the fiduciary role of those PBMs is what's key to impact their behavior. If that happens, those other things that we've talked about, banning spread pricing, one of the representatives mentioned delinking, and rebate model control. Those type things are necessary to change the business model so that the prices become affordable to both the plan and the plan members.
Thank you. And I guess I'll end my time by, I got very excited when I heard my colleague, Mr. Bean, talking about this idea that people could have health insurance that was not connected to an employer and they wouldn't have to change it all the time. And I just think that that was just such a ringing endorsement for the whole idea of the Affordable Care Act marketplace, that we really should concentrate some time on improving plans like that so that people who will have multiple options and that all of those options will be both affordable and accessible and will not be contingent upon employment or geography or what community you're from. And I really hope that we take the opportunity to improve the systems that we have in place to make them better for all to access. With that, I yield back. Thank you.
Thank you, Ms. Hayes. I now recognize myself for 5 minutes. Mr. DuBose and Mr. Behrens, state laws regulating pharmacy benefit managers have been the vehicles for litigation challenging the extent of ERISA preemption. However, I cannot emphasize enough that protecting ERISA preemption is not about regulating PBMs. Congress must understand how these state laws are the camel's nose under the tent. How do these lawsuits impact other service providers and other employee benefits under ERISA? Mr. Behrens.
Yes, I think you're exactly right that the way that states are looking at the response to the Rutledge decision and applying the laws go well beyond PBM regulation. If the idea is that the states can subvert the rights of this Congress to regulate employee benefit plans by regulating PBMs or TPAs, then that's going to have significant impacts.
Mr. DuBose.
I agree that protecting ERISA preemption is not about the states and their attempts to regulate PBMs. I believe ERISA has always been to provide a self-insured employers a federal regulatory framework to provide great benefits to their plan members. I just believe the states are reacting to a condition with pharmacy pricing. It's their attempt to rein that pricing in.
Yeah, so start with you, Mr. DuBose. How should Congress both protect ERISA and ensure proper oversight of PBMs?
I think Congress and policy does a good job in protecting ERISA. I think the arguments made at the state level are things that need to be addressed at the federal level. Things such as PBM, site-neutral payments that Medicare is proposing. Those type of things are very important, and we support those. And if those things were managed and taken care of at the federal level, then the states would not have to engage.
Mr. Behrens, do you have anything you'd like to add to that?
I think transparency is certainly important and helpful. I would argue that in addition to some of the efforts that are already underway ensuring that the information we are asking PBMs to disclose is disclosed timely. For example, if we're merely asking for rights to audit PBMs, those audits are very difficult and expensive. We would prefer to see regular data feeds of that information so that it is actionable during the plan year. In addition, when it comes to the fees, we believe that it is important for PBMs as well as TPAs and others to disclose their direct and indirect compensation.
Thank you. Ms. Mancino, anti-competitive contract terms are becoming more common as the healthcare market becomes increasingly consolidated. Do you believe that these anti-competitive practices inhibit a free market in healthcare?
Thank you for your question, Chairwoman. Yes, we do think that the market, the work that we see and the challenges that employers face in the market, they are challenged to unlock competition and their purchasing power today.
So how would you recommend Congress address this anti-competitive behavior?
Congress can seek to address anti-competitive behavior in concentrated markets in two primary ways: continue to advance data transparency, codify the price transparency requirements, push that further, make it clear that TPAs cannot hinder access to employer claims data, encourage the administration to implement the advanced explanation of benefits to give consumers actionable information as they make care decisions, and incentivize employers and health plans to contribute healthcare claims to multi-employer claims databases to drive better purchasing and design decisions, and finally prohibit all or nothing, most favored nation, and anti-tiering contracting practices.
Thank you very much. I had another question I wanted to ask, but I'm about to run out of time. It has to do with hospital charge facility fees, hospitals charging facility fees for telehealth appointments. Mr. Behrens, would you give a very quick answer to that issue?
We are very skeptical of facility fees in general, specifically with respect to telehealth when the only required technology is a phone line or internet connection.
Thank you very much. Mr. Scott, you're recognized for 5 minutes.
Thank you, Madam Chair. Ms. Handorf, we've talked about transparency. One of the shortcomings of transparency is it's just the first step. But I think you've alluded to the fact that if you had transparency, a lot of people wouldn't know what they were looking at. What does an employer know if he gets transparency?
Well, I think that is a problem and I think that's a problem with the 408B2 disclosures, because if you're going to get fees reported, you have to know that those actually are the fees that are being charged. And so what I think will happen is that if you get more access to the claims data, you'll be able to see how the fees are spent, how they're collected, and you will end up finding out more. But I think that really the answer is to make the TPAs and the PBMs fiduciaries under ERISA.
And how would making them fiduciaries improve things?
Well, it would make them responsible to the participants and beneficiaries. They would have to follow the fiduciary rules. They couldn't set their own compensation. They're basically running the healthcare plans anyway now. And it would just put the responsibility where the power is and the liability where it belongs.
Thank you. You talked about denial of benefits. When benefits are denied, do consumers get a de novo right of review when they go to court?
No, you get a discretionary standard of review, which means that that even if the judge thinks that you're right, if there's a reasonable basis for why the plan denied the claim, the court will have to affirm the denial. So it really does put a barrier in terms of people getting benefits, which is what ERISA is designed to do, is to provide for those benefits. So if you had a de novo review, the court would be looking at the record with a fresh eye and making a decision as to whether or not the benefit should be provided.
And are there other barriers like arbitration agreements that get in the way of consumers getting a fair day in court? Are there other barriers, arbitration agreements, for example, that serve as a barrier to consumers getting their fair day in court?
Yes, I understand that the employers want to control costs, but they put in their plan documents many things that keep participants from protecting their own rights, like class action waivers, arbitration provisions, venue provisions that cause people to have to go across the country to adjudicate their claims. They're all designed to keep people from protecting their interest. It's hard enough for employees to get representation in ERISA cases, but these make it even more difficult.
It's hard to get representation because many of the claims are only a few $1,000s, and you can't afford an attorney if that's all that's at stake. Is that right?
That's correct. Usually the claim will not be great enough that it makes sense for a lawyer to pursue the claim. So by allowing individuals to join together in a class action, they're able to effectively get relief for everybody.
And if the person, if the customer is successful, who pays the attorney's fee?
In a class action, it comes out of the recovery from the plan.
But if there's no class action, if it's an individual claim?
With an individual claim, it still comes out of the recovery. But what it does is it allows people to get lawyers who they otherwise couldn't get.
That's if there's a class action.
Yes, and there's a lot of risk bringing class actions, as I'm well aware. There's many barriers to bringing them. Article 3 standing provisions have kept many people from pursuing their claims.
Now, if there's an inappropriate denial that effectively causes malpractice, who's on the hook? And the insurance company essentially made the decision. What responsibility for the malpractice does the insurance company have?
It really doesn't, because the Supreme Court said that ERISA pays for benefits. If they deny you the right to a benefit, you still have the right to get the health care. You just have to pay for it yourself, which is effectively denying you the health care. But when insurers, for example, don't handle claims properly, they should be liable for the consequences of not doing so.
Gentleman's time's expired.
Thank you.
I now recognize Ms. Chavez-DeRemer from the state of Oregon.
Thank you, Madam Chair, for holding this important hearing on employer-provided health plans. And thank you to the witnesses for being here. Roughly 48% of Oregonians get their health care from their employer. In a lot of those plans, Oregonians have trouble getting past medically inappropriate step therapy protocols. It's been found that step therapy was applied to almost 40% of all specialty drug decisions in the largest commercial plans, and that many step therapy protocols went against clinical guidelines. Not surprising, since the people imposing step therapy are not doctors. All at the expense of people's health. As a business owner myself, I know this isn't the fault of employers, especially the small business folks. Pharmacy benefit managers, PBMs, are responsible for processing prescription drug claims, and they are implementing step therapy without any flexibility for any individual's patient medical history or needs. That's why I joined Representatives Wenstrup and McBath in introducing the Safe Step Act, and I hope this committee can advance it this Congress. Mr. Dubois, the Safe Step Act doesn't end PBM use of step therapy. It simply establishes a timely exceptions process. Do you think that's a fair balance between finding savings without causing harm to the patients?
We support the Safe Step Act. We do reserve the right to use step therapy. I think what's important for plan sponsors, especially small businesses, what they need to really ensure in their plan design for pharmacy is to make sure that they have independent analysis carved out for their authorizations for those specialty drugs. So as you mentioned, as those specialists, the doctors and the pharmacists, as they confer to decide, is it appropriate care? Because ultimately that's the purpose, is what is the most appropriate care for the right product at the right price at the right time? And by doing so, you provide the best medicine for that patient to reach the best desired outcome possible.
At the right cost. We also know that misaligned incentives, the current payment system, lead PBMs to favor medicines with high list prices and larger rebates. That's why I'm also proud to co-lead the Drug Act, which would crack down on PBMs who put the bottom line ahead of their clients' and patients' interests. As PBMs have faced exposure over their practices, they've actually shifted their compensation models to focus on administrative and other fees. And those fees have typically remained tied to the list prices. So even in cases where health plans may be receiving a substantial portion of rebates for PBMs, PBMs may still have an incentive to favor those higher list prices. This compensation model is causing patients to face insane prices for their prescription drugs. And for what reason? I mean, really, PBMs can manipulate the market, while Oregonians have to choose between going hungry and buying their medicine. And it's really quite shameful what we're seeing across the country. Dr. Behrens, I'm going to make sure I get that right. Thank you. Do you agree the Drug Act would help address these issues and help bring down costs for employers and patients?
First of all, I need to clarify I am not a doctor.
Oh, I have it wrong.
Just a Juris Doctor.
That's
just
okay.
A lawyer.
Take the credit where the credit is due.
I haven't specifically reviewed the legislation. I'd be happy to and follow up more with it. I do think one of the fundamental challenges here is the list prices and some of the prices that are charged to begin with. And a lot of the programs that are utilized, tools that are utilized, are to deal with those high prices. And so I appreciate the opportunity to look into that more and follow up.
Yeah, if you could follow up, review it, and get back with me, that would be great. PBM should not tie their compensation, in my opinion, to the price of medicine. That runs counter to the stated mission of lowering drug costs. Breaking the link between medicine list prices, rebates, and PBM compensation will go a long way in removing the incentives that pad the PBM's pockets. Madam Chairman, these are critical to lowering costs for patients and improving transparency for employers throughout our districts. I do hope we can move through this process as this Congress wraps up, and with that, I yield back my time.
Thank you. I now recognize Mr. Ranking Member Desaulnier for 5 minutes.
Very good. Your high school French succeeded. Well, thank you again to all the witnesses. The ERISA Advisory Council just released a report for people who are on permanent disability, long-term disability benefits, about behavioral health needs. The council found that 99% of long-term disability plans impose duration limits for people with disabilities arising from their behavioral health conditions, while not placing similar limitations on disability arising from physical health conditions. Ms. Handorf, could you briefly discuss how this fact squares with the concept of mental health parity?
I don't think it is consistent with the concept of mental health parity, because I think with mental health parity, Congress recognized that mental health conditions are just as serious as physical health conditions. So you should have parity. People should be treated equally. I think that's a public policy that's been well established. So it really makes no sense for disability plans to have different standards for mental health disability and physical health disability. They should be the same, because the impact is exactly the same.
Exactly. Just this past week, the New York Times did a front page story examining a company called Multiplan, a private equity-backed data and analytics firm that works with third-party administrators of ERISA health plans. The practices described are shocking, shortchanging healthcare providers and leaving patients on the hook, often with bills amounting to tens of thousands of dollars. Anecdotally, I've heard from friends of mine, providers, long-term primary care providers, just talking about how much time they're spending on challenges to what used to be normally provided by healthcare plans. and just the waste of that in the system. Ms. Handorf, how did this company in particular make its money, and who ends up bearing the cost of the savings it achieved when patients are the ones who are billed for the difference?
I think it's still a secret as to exactly who bears the cost, because I think that most plans don't even realize there's a saving fee attached to the payment. We've seen cases where a provider's paid $1,500 and there's a $30,000 savings fees attached to it, and it goes to the plan as the benefit payment of $31,500. What's not clear is whether the patient, the employee, has to pay a higher co-insurance because of that. But we do know from the New York Times article that the providers will then bill the patient, and the patient is then obligated to pay more. So I think this is probably, I've seen this a lot in plans. They're usually described as savings fees for catching fraud and abuse. In fact, they're fees for just bullying a provider into taking a lesser payment.
And just, again, anecdotally hearing from friends who have been doctors for a long time here in the D.C. area and in my district in the San Francisco Bay Area about calling me and saying, everything's changed. We've been providing the same kind of advice with the same kind of financial support for years. But here's an example with not just the direct costs that are lost to the person who's impacted by this, to the person who's seeking advice in healthcare, but also the doctors and primary care doctors who don't have the kind of staff, but have the kind of trust and relationship with their patients. It's a real problem. I thought it was fascinating what the New York Times did with it, and it seems like for efficiency, we should be able to do something at a bipartisan level for employers and for the patients. The General Accounting Office recently noted that the Employee Benefit Security Agency at DOL has been almost flat funded for over a decade, even as its responsibility have grown enormously during the time due to legislation like the Affordable Care Act. This has been a strategy by some of my Republican colleagues. Don't provide the funding to actually regulate what the law says. Ms. Sandorf, you have any comments?
Well, I think that without I worked for the Department of Labor for many years, and it's a big task. And I think that without the funding, you're putting a Band-Aid on enforcement. You need a lot of money to investigate some big insurers. They're not going to want to give you the information that you need. And the problem is that not only does the department not have the resources to do it, but employees don't have the ability to do it for themselves. So it's really important that the department have money.
Thank you. And I would like unanimous consent to submit for the record a letter that Mr. Scott and I have sent to the Department of Labor, and also a letter from Sun Life. Thank you, and I yield back.
Without objection. I now recognize myself for 5 minutes. Thank you for testifying before us today. We are grateful for your time. I've had the chance to speak with individuals and stakeholders on literally every side of this PBM reform issue, and I'm hopeful that there are some policies we can agree on to increase transparency and oversight with respect to PBMs, and to reduce cost and address the concerns that I've been hearing from constituents and pharmacists alike. One such complaint is that there are 3 PBMs at this time that control the vast majority of prescription claims for the United States. In fact, their combined market share has skyrocketed from 48% in 2010 to 80% in 2022. While the PBM industry says there's a lot of competition in the PBM marketplace, I worry that self-insured employers actually don't have much choice. I continue to hear from my community and independent pharmacies frustration about the lack of meaningful action in Congress to rein in PBMs, and I agree. I was a proud supporter of the Lower Cost, More Transparency Act, which overwhelmingly passed the House of Representatives on a bipartisan basis last December, including some of my own language on the Hidden Fees Disclosure Act, yet as it sits in the Senate, unmoved. Mr. DuBose, you stated in your testimony that the recent increase in state laws seeking to regulate PBMs is caused in part by the vacuum created by lack of action in Washington on PBM abuses at the federal level, and again, I agree. As I continue to have these conversations and continue researching on this matter, I would certainly appreciate you sharing your expertise. Mr. DuBose, how do you think Congress can help ensure more competition in the PBM market so employers do have real choices?
Yes, I agree. The big three have taken over the market share within self-insured space. They do that because most employers subscribe to the rebate model that is in place. Those big three BMs, they own the aggregators in which rebates flow through from the manufacturers. So they own the pipeline. So for employers, plan sponsors, they have to get educated, and then they have to identify and find high-performing, transparent PBMs. I believe the key is they have to connect with PBMs that are willing to serve as fiduciaries until the law is changed in which decrees states that PBMs are fiduciaries. That's who they need to seek, because then the plan design will move away to an administrative fee model to where it becomes transparent, and then the PBM is working with you to protect the interest of the plan members. And then we both seek to find the lowest net cost solution and to move away from an older paradigm that only enriches those big three companies.
Is vertical integration an issue?
Yes. Actually, I believe it is the bigger issue from spread pricing. Delinking is very important as well because it drives that vertical integration where they own the pharmacies, especially mail order. So they're essentially selling to themselves. When you do that, the spread pricing really is not that important.
So should pharmacies and insurance companies be able to own PBMs?
Yeah, in a free market, if a pharmacy wishes to own a PBM, I'm not opposed to that, but I do believe that PBM should be a fiduciary and they should understand that obligation.
And should they be able to mandate that it's their PBM that must be used? Or should
Absolutely not.
And should they be required to not only be transparent, but be subject to oversight and accountability?
Absolutely.
How would having some uniform standards in place for PBMs help drug pricing and just the overall marketplace in general?
The standards are incredibly important because that's where the employers, those plan sponsors, fall down. When you don't have transparency and you can't see the data, it's so opaque, you can't craft good policy, which means you can't craft good plan design, and then that's where the plan suffers and fails to meet the needs of the plan members. So I believe transparency has to come first, and then with those prohibition on those practices, then the right pathways align.
Thank you. I appreciate your knowledge on the topic. Hope that this Congress, we will continue to consider how we can address it and improve not only drug prices and cost transparency, but the overall marketplace. I yield back my time. I'd now like to recognize the ranking member for a closing statement. Mr. DeSaulnier, you are now recognized.
Thank you. I want to thank the chair and the committee and the witnesses as well for your testimony. Thanks for spending your time with us. 50 years ago, Congress took action and passed the Employee Retirement Income Securities Act, or ERISA, to protect the interest of millions of workers and their families who receive retirement benefits and health care through their employer. As I noted at the beginning of this hearing, it is critical to understand the significance of job-based coverage here in the United States. Over 164 million workers and their families benefit from health care coverage they receive through their jobs. However, time and ever-evolving workforce and healthcare industry have revealed that ERISA has failed to live up to its promise for millions of Americans. Significant gaps in healthcare coverage and exorbitant costs for hospitals, physicians, and life-saving prescription medications continue to squeeze workers out of their last dollar. And loopholes continue to allow large, unscrupulous insurers to engage in practices that raise costs for both workers and their employers. Democrats have worked tirelessly to strengthen ERISA, promote access to care, and lower health care prices, but there is still room for improvement only if consumer protections remain in place and become more efficient. I look forward to working with the majority to see if we can find a common interest to accomplish this. And I welcome and hope for earnest engagement with Republican colleagues so we can fully support employers and workers and continue to build our economy from the bottom up and the middle out. I yield back.
Thank you. I now recognize myself for closing remarks. On behalf of the 153 million Americans whose health care benefits rely on ERISA, I think we've certainly learned a lot today about how we can improve the law. It's clear to me there are areas where government should get out of the way, like streamlining paperwork requirements. ERISA was created to reduce the regulatory burden that would arise from complying with various state laws. We shouldn't replace regulatory relief with more regulation. In other areas, clarity is needed. I'm particularly interested in how increased transparency will provide employers and ultimately patients with cost information for healthcare services. In the age of technology, it's time we move past these unknown and unexplained high healthcare costs. Employers and patients both deserve to know the price of care. Congress should protect the ERISA preemption so that multi-state employers can continue to easily offer benefits across state lines. Protecting this provision will preserve the private health insurance system and shield America from devolving into a single-payer system. Thank you certainly to our witnesses for your time and for your insightful testimony. Without objection, there being no further business, the subcommittee stands adjourned.